Hey, Dental Nachos crew, it's Paul, Dr. Nacho. We're going to share with you an awesome topic, how dentists can use mini implants to help solve problems for their patients. I am here with the awesome Dr. Erwood, someone who uses mini implants and all types of implants here on Talking Nachos. We're going to talk about the More Implant System from our key resource and sponsor, Stern Gold. We have some people in the chat. If you have any questions, you can feel free to ask them in the chat or Facebook Live. But welcome, Dr. Ian, to Talking Nachos. How's the day going for you?
Hey, good. It's going great, Paul. Fantastic day. Had a busy shift this morning, and I'm here doing the podcast now. So it's been
I like how you refer
excellent.
to it. I'm going to start referring to my things as dental shifts, right? I did a dental shift. My shift is over. You know, I like that.
No, that's the way we run our office. We do 2 6-hour shifts a day. First shift comes in at 7:30, finishes off just after 1. Second shift comes in just after 1, finishes at about just after 7 tonight.
Oh, nice. I like that.
We have 3 hygienists on each shift, and so we go full bore all day long.
So you're like a hockey changeover. You should make people like jump over the boards.
That's right. It's pretty close on our changeover. It's almost like that.
Awesome. Well, we're going to talk about the More Implant System, our awesome sponsor, Stern Gold. If you text Stern to 55444, text Stern to 55444 while you're watching, you get an awesome discount from Stern Gold and learn more about their product. So share with me first, Dr. Erwood, what got you into using mini implants and implants in general, and how GPs, prosthodontists now could use mini implants to help them?
Sure. Well, when I graduated from the University of Western Ontario, we had very little implantology training. Yeah. But as soon as I graduated from dental school, I wanted to learn more about implants. So it was still on the fringe in those days. And I go back to the time when Branamark was just coming out, and the implants got delivered to you in a non-sterilized vial, and you would put the implants in a sterilizer to sterilize them before you put them in. So that's how far I go back.
I have to say, you've been a dentist for how many years?
33 years now.
You're aging in reverse, like dentists. You look like you're young, so I need to learn on that. So you've been doing implants for over 3 decades. So that is what now sounds like I always think that what was normal in one moment sounds funny later, right? When you guys were doing that, sterilizing the implants, you thought we were at the top of our game here, and now we find that to be, humorous.
Exactly. There was no such thing as even an angled abutment when I first started working with implants. And I found out about mini implants, I guess, after about 10 years of placing regular diameter implants. And I was at an implant conference just outside Tampa. And at one of the booths, they had these mini implants, and I looked and I saw them, and I thought, this is radically different from what I am presently doing with regular diameter implants in the office. And it just happened that one of the guest speakers at this conference was Dr. Charles English. Dr. Charles English was one of the most notable prosthodontists in the world, especially in the field of implantology. And he was a great troubleshooter. He would do his presentations, he would talk about difficult cases and how he would overcome them and all the obstacles related to implantology. And he was from Little Rock, Arkansas.
Oh, cool.
Anyways, there was probably, I attended one of his lectures at this meeting. There were probably 300 or 400 doctors in the lecture. And I had some questions for him afterwards, and there were about 50 doctors in line to ask him some questions. I was doctor number 50.
Oh, wow.
And so by the time I got to him, the auditorium was empty, and he said, "Do you mind? I'm happy to answer your question. Do you mind if we sit down?" So he answered my question, and we chatted for a minute. And I said, "Dr. English, did you see that mini dental implant booth that was out in the hallway there?" And he goes, "Yeah, I saw that." He said, "If those things work, that company's really got something there." So I thought, if Dr. English is interested, I'm going to go back and take a second, third look. And so I went back. I said, okay, I think I'm going to get into this system. But I made the mistake. They had a show special on to buy the whole kit type of thing. I made the mistake of just buying a few parts and pieces. And at that time, I had a 10-minute video on how to. That was your educational experience.
That was the early day of YouTube, right?
That's right. This was before YouTube.
Yeah, right.
This was before the internet.
Oh, wow.
We're going back to VHS and beta.
Yeah.
So we're going way back. Anyway, so I took the system home, and the initial indications basically were stabilization of a lower denture. And I chose my first 3 cases. I didn't even know if they were difficult, advanced, or routine, but all 3 worked out fantastic. Patients were ecstatic about it. But I soon realized after a few months of working with the system that I needed a few more of the parts and pieces that I didn't purchase originally. So I had to phone the company back up, say, oh, I need these other parts, which I eventually got. And that's how I really got started with the system. And it was excellent that I had such good success right away, because it was new territory for me. And if I had maybe those cases had failed, I would have said, they don't work. You know, it's garbage. I'm not doing it.
One thing I like to dig into that, Erwood, because I appreciate sharing the story. So you were doing regular implants, and I like this switch. You know, so sometimes people are doing no implants. They start with mini or regular. Us regular implanters, I've done select cases of yours. Sometimes we have not really been open-minded to using mini. So you're living this world. So from a patient perspective, and also sharing a little bit about Stern Gold system, the more implant system you're using now, what makes that unique? And also, how are you communicating this to patients?
Yeah, so what makes the more system unique is that they have a whole range of sizes that I can adapt to the cases that I need. They come in 3 different diameters: a 2.1, a 2.4, and a 3.0.
Gotcha.
And various lengths, ranging the lengths that I use in my practice predominantly range from 10 millimeters up to 15 millimeters.
Yeah.
And so that helps me. And they have, for stabilization of upper dentures or lower dentures or partial dentures, they have 2 different options of the housings that you pick up inside the denture for retention.
Gotcha.
And so that gives me enough options that I can deal with the Stern Gold More system and be successful with my cases.
I always like this idea, Erwood, because it's not easy to be a dentist. And I happen to, you know, someone has a denture, they hate it. You give them implants, they go, now it's too tight. I go, that's the way it's supposed to be.
Yeah, exactly.
Like to lose, but the ability to change retention, and I say it jokingly, but you know, one day I'll be, you know, hopefully 70, 80, and you know, dexterity can be challenging. So
exactly. I always say to patients as well, be careful what you wish for. And if they come and say, oh, it's too retentive, sometimes I say to them, if I could give every patient a denture this retentive, patients would be lined up out the door. They'd have to take a number to get in.
Yeah, I always say there'd be a lot of patients jealous of what you have. That helps.
Exactly.
That helps them out. Now, you know, one of the things I like to do is, you know, Dental Nachos, Dr. Nachos, is to motivate dentists to just find out, take the first step. So if someone's watching this now or in the future, and they're thinking, you know, I would like to get involved with mini implants, what advice could you give them as the next step? Of course, they could take, what should they buy? You know, what would you, if you were doing this now and advising someone, what would be some advice you'd give them?
Sure. So one thing, it depends on your background, whether you're a seasoned implantologist, you know, you've been placing, restoring implants, you have a good surgical background already. That's one thing. Or you could be at the other end of the scale. Maybe you're a recent graduate and you haven't placed an implant before. What should I do? So we'll look at more or less both scenarios. So for the seasoned implantologist, they've got to realize that there are some differences with placing mini implants and restoring them versus regular diameter implants. And this can be a problem because some seasoned implantologists will say, oh, maybe I'll just try those mini implants, and they buy a kit. They don't get any education at all. And they come across a case, maybe in the posterior maxilla, the bone's not very dense, don't have a very wide ridge. And they say, oh, patient doesn't want to do any grafting to build up that ridge. I'll just put a mini implant in there and, you know, I can probably fit one in. Well, that's probably the worst place to place a mini implant in the mouth. They go ahead, they do it, and it fails. And they say, oh, those mini implants are garbage. I'll never use this kit again.
So what I'm here to say, and I love this, because I teach this with my first implants, case selection, whether you're a pro or a novice, is key.
100%.
Yeah.
You know, it goes for almost anything in dentistry: prosthetics, orthodontics, perio. It's all about case selection for sure. And so the mini implants are different surgically because typically you load them that day, unlike most regular diameter implants where you'll bury them or maybe put a healing abutment on and just leave it for 3 to 9 months, whatever, before you restore them. The mini implants, you typically restore them that day. And so as a result, you have to have them stable. I placed 3 mini implants yesterday and in the maxilla, and I was able to achieve anywhere from 40 to 50 newtons torquing force on all 3 of them. And they're like rock solid.
That's great.
The osteotomy is different because unlike regular diameter implants, some companies will tell you, oh, this implant we have is self-tapping, but it really isn't self-tapping, because with most regular diameter implants, you're drilling an osteotomy almost the same size as the implant that you're placing. And that's the last thing you want to do with a mini implant. You do that, you've got virtually 100% failure rate. Gotcha. So with the mini implants, all you're doing is drilling a pilot hole and being able to guide that mini implant into the pilot hole. You get through the dense cortical plate, and it will self-tap its way through the bone.
Yeah.
And the length of your pilot drill is dependent on the density of the bone. If the bone is not very dense, then you may drill up to 1/3 the length of the mini implant you're placing. And by the way, I don't raise a flap. This is done right through the gingiva.
I mean, and what I'm hearing is, you know, it's especially during this Nacho Nuts pandemic time, anytime you can help a patient, you know, with something that's truly life-changing. I'll share one of the mini implant cases I did as a resident in 2000, or I guided her in 2008. That patient still comes in 12 years later, and he always says, I'm so glad we did that back then. So there's these life-changing moments, but what you're sharing is really important, because what is that everything has to be done responsibly. Build your education responsibly for 2 reasons. 1, we're working on people, and 2, if not, you're going to give up. You know, I use it like driving. If you start out driving a car, you go on a road that's too dangerous. Even if you survive, you say, I don't want to do this anymore. So if you're listening, it's so key to build up your education in a way that makes sense.
And you've got to walk before you can run. So you can, if you've got really dense bones, say lower anterior mandible, you can drill up to about 2/3 the length of the implant, the mini implant, to place it, because you've got to achieve at least about 30 Newton centimeters in order to load these right away. Yeah. And that's something that an implantologist currently placing regular diameter implants doesn't understand. Right. You know, they're not used to that. They're not used to drilling one pilot hole right through the gingiva and placing that implant. And so you were right. You need to select the right patient, and your diagnostic workup has to be key. You have to know the bone thickness. You have to know the anatomy, where the nerves, the blood vessels are.
What are you doing for your evaluation? So now let's talk about a novice. They're saying, okay, I'm not
sure. Okay, so let's
go to the novice, because the pro is not necessarily going to be as worried about anatomy. They're used to that. So now go to the novice. Let's build someone up from scratch.
So if you're starting as a novice right from scratch, you want to start with complete lower denture stabilization. You want to make sure they have a relatively healthy ridge, not a resorbed ridge, and the patient has been edentulous for 30, 40 years. Right, yes. That's going to be a resorbed ridge that's going to be very difficult to restore. I've done cases like that, but that's much more advanced. So you want a relatively healthy ridge. Let's say a typical case might be a patient's had a partial denture, lower partial denture. Yeah. They've, maybe from cuspid to cuspid, they've had their remaining teeth. Those teeth get periodontally involved. They lose them. Now they transition into a complete lower denture. Now they hate it. They hate it. The partial denture, at least they had some clasp, it still moved around. And now they want nothing to do with this complete lower denture. that's, an ideal case. Once the ridge is healed, now you can still have probably some bone to work with between the mental foramens.
Yeah.
And so diagnostically, in most cases, if I have a healthy patient, I can work from a Panorex and then do some bone sounding,
Gotcha.
where I may take a sharp probe through the gingiva and find the depth of the bone or the thickness of the soft tissue, and that will allow me to figure out the thickness of the bone. If I'm with a more difficult case, or maybe if you're just starting out, maybe you're more comfortable getting a CT scan.
I think it's a great point. It's interesting. My dad, I had an awesome opportunity to work with him for many years. Panorexes were the new thing at some point.
Yes.
Now they're, the CBCTs are being put into offices with greater frequency, which is great. So if you have that, you can utilize that for real, the height, and the width, and make yourself feel comfortable in knowing, easy, medium, hard, right?
Excellent.
Easy, medium, hard.
Exactly. So CTs are becoming the gold standard, and if you have easy access to them, then by far that's the way to go.
Yeah, and I would add in, as you're giving us such great value, are you extracting teeth now, right? If you're extracting teeth now, possibly doing bone preservation, you can add in the reverse of the extraction with his implant dentistry. So, it's interesting to me, and maybe because how I learned, people say, I'm afraid to do implant dentistry. I say, okay, no problem. How many teeth do you extract a year? 700. I go, oh, yes. Well, you're ready. You're doing something harder right now.
Exactly. It reminded me when I was back in dental school in our oral surgery rotation, we would have some poor patient in the chair, and we'd have 2 or 3 of my classmates in the room, and we'd look at the case. It might be, extracting an upper first molar, and all we would care about was how fast we could get it out.
Right.
And we'd say, okay, someone would say, I can get that out in 20 minutes. Okay, I can do 15. I can do 12. Okay, you're on. And we would bet for beer after class.
Okay.
And so, but we would section it. We would drill the bone away and then get the tooth out as fast as we could. Then with the advent of implants, all of a sudden that bone is precious.
Yeah.
And so you want to preserve that ridge as much as possible. So it's important, if you're not already, you need to learn how to do atraumatic bone preserving extractions, no matter what tooth you're taking out. And that bone is golden now. Even if the patient's not considering implants right away, maybe down the future they may be.
For sure. I mean, I've had many patients, and I laugh, so I got to start tipping. They go, I'm never getting implants, no matter what. I say, okay, no problem. See how you like these dentures. They go, I need implants now. I said, I know. I wait. And then it's a fun joke. Now they have overdentures or things like that. So, I mean, this to me is an awesome opportunity. You've shared in such a systematic way for anyone to know it. Erwood, before we jump off here, I want to do a couple things. One, you can text Stern to 55444 to get information from our key resource and sponsor, Stern Gold. We're awesome. They also have a Nacho discount for you. Dr. Erwood, I always say, in closing here on Talking Nachos, you're talking out there, looking at dentists. What's one thing you want to leave them with, or one thing where you say, hey guys, I've been a dentist, I still can't believe it, 33 years. This is what I would do if I was in your shoes.
So first of all, look at incorporating mini implants into your practice. If you're not already, get educated. Stern Gold offers some great educational experiences, and whether you're a seasoned implantologist, you can put it in your bag, and or if you're just not just starting with implantology, then think about incorporating mini implants and start with stabilizing a lower denture with 4 mini implants. It's relatively straightforward. I can teach someone in grade 1 how to do it, but it's the treatment planning that's the key. As you started off, you select the right cases. You can do them with your eyes closed, but it's important to pick those cases. Start slow, get some experience under your feet, and then grow from there. I get doctors sending me cases where patients drive 2 or 3 hours away from me to have these mini implants placed. These patients drive past over 2,000 dentists to see me.
Yeah, so this is a great opportunity to join us. I love that share. What I'll share as we wrap up is, I've been a dentist for 18 years. Let me tell you how many times people have gotten up from after a filling and thanked me. 0 times, 0 times. But with dentures, and you change people's lives, and it's a cool thing to do. It makes you feel better. It makes your team feel better. Thanks for sharing with us, Dr. Erwood. We
It's
really
been great.
appreciate it. Really enjoy it.
Thank you so much.